Good afternoon, everyone, and welcome to our presentation today. Again, I must apologize for our glitch with our Zoom, but we're so glad you can join us. I do have a few announcements before we get started on the presentation. Next slide.
They're not advancing. Okay, let's try this again. I'm sorry, Trish, it froze. Let's try this again. There we go.
So right now, Deb, the slides aren't up.
All right, let's try that again. Is it up now?
No, it's not.
It is on mine.
So you're not on, yeah, go off of share screen.
Let's try again. How about now?
Yes, there they are. Okay. So as far as some announcements for today, for the requirements to complete the program and get your CEs, you'll need to register, view the entire webinar, complete an online post-test with a minimum score of 80, and complete an online evaluation. Sponsorship or commercial support was provided by no companies. As far as non-endorsement of products, the accreditation status does not imply endorsement of any products mentioned by NJSNA, ANCC, or Central Jersey Family Health Consortium. And as far as conflicts of interest, all planning committee members and faculty were selected to avoid any conflicts of interest. And disclosure forms were required, and the program coordinator has reviewed them for any issues. Next.
They're not advancing again. Is that working?
That is.
Okay.
But still not advancing for you?
There we go.
There. Speaker disclosure, the speaker does not have anything to disclose and there is no financial relationships to disclose. Next. Okay, great. So right now what we're going to do is questions will be held to the end of the presentation. I ask you all to put your questions in the chat box and we will answer them at the end. All cameras will be turned off. You will receive an email next week with a link to a post-test and evaluation, and you will have 48 hours to complete it. And once you complete it, you will receive a certification. So I'd like to right now introduce our speaker. It is with honor and great respect that I introduce my colleague, Debbie Rasica. She began her career as an occupational therapist before specializing in addiction. Graduating from Quinnipiac College, Debbie worked at Muhlenberg Hospital for 7 years as a senior therapist for psychiatric patients, as well as for patients detoxifying from drugs and alcohol. Additionally, Debbie served as the senior clinician in a long-term residential drug treatment program for 10 years. For the past 13 years and presently, Debbie serves as the manager for the Perinatal Addiction Prevention Project at Central Jersey Family Health Consortium. This program offers education, advocacy, outreach, prevention, and interventions to reduce maternal and fetal complications from substance use, trauma, along with risks of substance use on developing brains. While at Central Jersey Family Health Consortium, Debbie also became a women's treatment specialist, a certified tobacco treatment specialist, and a certified state educator for fetal alcohol spectrum disorders. In addition, Debbie joined the New Jersey Coalition Against Human Trafficking and is involved in activities including participating in healthcare committees, trained to present human trafficking as a member of the Healthcare Speakers Bureau, and also co-chair of the working group for the Healthcare Outreach Committee. So again, I introduce to you Debbie Rasica.
Thanks, Trish. Okay, I guess we should get started. We lost a little bit of time. So welcome, everybody. Here are the objectives for today. We're going to talk about substance use disorder, maternal fetal implications of opiate substance use disorder, benefits of medication-assisted treatment during pregnancy, major concerns from alcohol use during pregnancy, and recommendations concerning marijuana use during and after pregnancy. And we're also going to identify resources for pregnant women struggling with substance abuse. So I just wanted to start with just talking a little bit about what substance use disorder is. And basically, you need 3 of the following within a 12-month period to be diagnosed with a substance use disorder per the DSM-5. The first is developing tolerance to a substance use, meaning, of course, you need more of that substance to achieve your desired effect. With the absence of a substance, folks will experience withdrawal. They tend to use more than intended and are unable to cut down or control their use. It's a lot of hard work to keep a substance use disorder active, and it really does interrupt usual activities in the course of a day. And despite knowing what the consequences may be of substance use, the use does continue and folks are not able to cut down. So we know that substance use disorder is not a choice. It really can happen to anybody at any time and anywhere. And it's not a discriminatory disorder. It does not depend on financial status, level of education, race, creed, cultural background, or any other factors. This is chronic, it is progressive, and it is very similar to diabetes or cancer or high blood pressure, that it is a lifelong disease, and it really does depend on behaviors to be able to manage and control this disorder. Okay. There are many risk factors that really contribute to a person being more vulnerable to becoming ill with this disorder. The first is very important. Family history of mental health issues and or substance use problems does account for 40 to 60% of vulnerability to addiction. So knowing family history is really critical in helping with intervention. If there is any active addiction, mental health issues, or any other traumas happening within the home during childhood years, that also increases the risk. In addition, the earlier a person first uses, the greater the chance of addiction. So a person who first uses at age 15 is actually 7 times more likely to develop a substance use disorder than if they held off that first use until they're 21 years of age. Again, that's why that education is so important. If a person experiences severe trauma, injury, disease, that also can increase the likelihood of substance use disorder, especially if we're dealing with pain management. And sometimes substance use is a result of folks self-medicating because of an imbalanced brain chemistry. So a person who's feeling depressed, highly anxious, difficulty with social interaction, these may be reasons for a person to begin use. Peer pressure plays a very large role in our youth developing a substance use disorder. As we know, it's so hard to say no to peers and to deal with that rejection. Environment matters a lot. If folks are moving around a lot, if they're unable to establish a strong community connection, it can also be a high level of risk. And there are also personality characteristics that play a role. The earlier a person uses, the less likely their cortex will fully develop. And if all of the functions of the thinking part of the brain do not have a full chance to develop, it can really increase that risk of a substance use disorder developing. And lastly, this one is also incredibly important. If there is exposure to substances in utero, that fetus, as they grow into early adulthood, can easily develop a substance use disorder. Other risk factors include showing of aggressive or impulsive behavior, low self-esteem, feelings of social rejection, lack of nurturing by parents or caregivers, not doing well in school, availability of substances. We know that access plays a big role, and the message that substance use is okay, which is very present in today's world with the mixed messaging that our youth are receiving. There are protective factors that can really help avoid a substance use disorder from developing. Parental support is paramount. So a lot of times we don't feel we're doing much as parents to control this, but we really do matter. Having positive, healthy relationships is also key. And as I mentioned in the previous slide, the later a person can delay that first onset of use, the better off they are. Having the chance to develop skills such as consequential thinking, healthy coping skills, problem solving, and decision-making skills also really matter. So having a chance for that prefrontal cortex to develop is very important. Education, as we know, is one of the best preventative measures we can take, and also can help early on with beginning use to provide interventions. And of course, we need our policies to match the messaging that we're trying to provide with our prevention work and our education. And we also need community to invest in the importance of spreading this education and providing all of the prevention that we can. So the most common drugs used by women include alcohol, marijuana, and opioids, which include both prescription pain medication as well as heroin, which is often bought on the street. Women who most fit the profile for substance use abuse include a low income level below poverty, experience of trauma as a child. We are all learning to be trauma informed and to learn about ACEs so that we can identify the trauma experienced. Again, history of depression, anxiety, or other mental health problems, as previously mentioned, lack of education, being single, unemployed, and involvement in the criminal justice system, whether as a victim or a perpetrator. This slide talks a bit about preferred language when we are interacting with people. We do want to avoid words like addict, abuser, or junkie. Those terms really lead to stigma. Sorry, Francis' fault. We want to talk about a person actively using. They are not identified as an addict. They're identified as a person with a substance use disorder. Abuse is also negative. We'd rather use terms like misuse and harmful use and experiencing hazardous problems as a result of risky use. Using the terms clean or dirty for drug results also is stigmatizing. We definitely prefer a negative or positive substance screen on drug testing. And this isn't a habit, it's a disorder. It's active addiction. It's not that someone's choosing to have problems with their substance use. And lastly, we want to use terms like medication-assisted treatment versus substitution therapy. And we'll talk a little bit more about MAT as we go on in our slides. Okay. This picture just represents the activity that happens within a brain that of someone who is using versus a healthy brain. And the healthy brain is on the left. You can see that there is much more brain activity going on. That's what we're striving for. We want people to be able to meet their potential and have fully healthy functioning brains. So how do you even ask questions in regard to substance use? Most important, non-threatening language, as we just reviewed in the prior slide. We also want to be very conscious of our body language. It's very easy for us to be multitasking as we're interacting with patients. And without realizing it, we might be giving off signals either facially or through the position of our bodies. So we need to present as open, arms not crossed, maintaining good eye contact, and really providing that patient with all of your attention. Non-judgmental questions are so important. It's important to say, oh, I see that you're still struggling with your cigarette smoking. Can you tell me how that's going for you? Versus, you're not smoking, are you? You can see how those can give very different messages. And we also want to be matter of fact as we ask these questions. And it can be even part of a regular history taking so that these questions are normalized. It's also helpful to let the patient know that you ask these questions of all patients because we want to ensure the best healthy outcomes for them. We really promote the use of the 4 Ps, which is a perinatal risk assessment, and it addresses alcohol use, tobacco use, other drugs, as well as domestic violence and other experiences of trauma. And the way we ask these questions is first starting with their parents' history of use, then moving to partners' history of use, and present and past use for the patient themselves. We cannot make assumptions based on how a person presents, how they look, how they speak. And the thing that's so important to know is that we do not have to have the answers to these questions. We just need to acknowledge them, validate them, and be able to offer brief interventions and other sources to get the help that people need. So what might you see if a person is presenting who is under the influence? You might see slurred speech, lability of their mood, mistrust of authority figures. Patients typically welcome the healthcare professional who's helping them. But that's not necessarily the case with someone who is under the influence and struggling with their substance use. Very typically, there's a lot of mistrust. You also may see inappropriate behavior, a lot of agitation and restlessness, and a person expressing unhealthy coping mechanisms such as denial, blame, rationalizing their use, and also minimizing their use. Those should be red flags that something might be going on. Unfortunately, when substance use progresses to abuse and dependence, a lot of problems may develop. These include problems with physical health, ability to function psychologically, difficulties with interpersonal relationships and impaired social relationships. Occupational functioning can really be impacted, whether it's work, role as a parent, role as a student, whatever the case may be, even including interests that typically people will engage in. Financial problems can definitely ensue. Substance use is expensive, and folks typically will run into difficulty with their finances. And this can all lead to spiritual bankruptcy, and again, that criminal involvement. So what might we see if a patient is presenting with symptoms of withdrawal? There will be an increase in the respiratory rate, very wide mouth yawning, not that discreet yawn that you hide behind your hand, but that wide mouth yawning that is difficult to control. You might see tremors as well as muscle spasms, heightened anxiety, nausea, including vomiting, anorexia. People can be definitely be malnourished as a result of their substance use. They might be experiencing piloerection, dilated pupils, which is a good telltale sign, tachycardia, diarrhea, lacrimation, the eyes just cannot stop tearing, and overall weakness is another symptom of withdrawal. So I'd like to now look at what are the negative consequences for moms as well as their babies with substance use during pregnancy. With our moms, we will see a faster heartbeat, higher blood pressure, changed in their cognitive thinking, poor nutrition, agitation, that word keeps coming up, and complications with labor and delivery. Okay. PCP also can cause very specific damage to the baby's eyes. The baby can develop behavioral problems, and they very likely may be born with small brains and damage to their central nervous system, development. With cocaine, we do see a lot of miscarriage, again, poor nutrition, that high rate of heartbeat, high blood pressure, and there is a very, very high risk of placental abruption and bleeding with use of cocaine. And very often, moms may not make it past their 8th month if they are using cocaine or crack during their pregnancy. And unfortunately, we do find that many pregnant women do opt to use cocaine or crack so that they can keep their own weight down during pregnancy and actually like the thought of delivering earlier rather than later. These babies often suffer with a low birth weight, a very small head and brain. They will experience withdrawal symptoms at birth. There's also a higher risk for SIDS with this baby. And there also can be genitourinary abnormalities that may occur once the baby is born. Okay. Now we're looking at amphetamines. They too can cause miscarriage, lack of sleep, faster heartbeat, high blood pressure, weight loss, and decreased blood flow to the placenta. Again, these babies will present with low birth weight, a small head and brain, heart defects, behavioral problems, as well as an increase in risk of SIDS. Okay. Now we're going to look at prescription pain medication as well as heroin. We are seeing more of this, and particularly during time of COVID. But let's look at a profile of a woman who is most likely to be experiencing substance use difficulties. As we know, at least half of pregnancies are unplanned. And it's been reported by ACOG that women of childbearing age are filling prescriptions more and more. 39% are on Medicaid and 28% have private insurance. So again, it shows that there is no discrepancy or prejudice with people who might be experiencing some issues. And the increase does parallel the epidemic observed in the general public. Overall, substance use has increased for all populations during this time of COVID. Okay. Opioids definitely can decrease core bodily functions and tolerance to pain, which can present a great difficulty during labor and delivery. There might be a life-altering loss of motivation, and a sense of increased sedation and drug-seeking behaviors. And along with that loss of interpersonal skills in building their relationships, really can be very impactful. So opiate use, again, greatly impacts mom as well as her baby. So this creates a slower heartbeat in mom, slower respiration, increased risk of infection, decrease in oxygen being distributed throughout mom and throughout her blood for her baby. There is high risk of spontaneous abortion, premature labor, STIs, again, placental abruption, which we know can be fatal, and hypertensive disorders. Babies typically will be born, again, with a low birth weight and a small head and brain, and they may show signs of withdrawal at birth and be at higher risk for developing addiction. Babies are not born addicted. They are born going through withdrawal. They do not meet any of the other criteria necessary to diagnose a substance use disorder. Babies are also at risk of being born with stillbirth, and that increased risk of SIDS again. So why do we want to really promote medically assisted treatment? Well, we'd like to avoid premature death, moms becoming ill with HIV and AIDS, hepatitis B or C, other sexually transmitted infections, liver disease from their alcohol use. It's important to note that moms struggling with any substance are probably using multiple substances. People do not limit their use to one substance. They often will add alcohol, and they're smoking cigarettes and other substances as well. We also need to be concerned about physical and mental health problems, and of course, loss of fetus if pregnant. This next slide looks at the high incidence of neonatal abstinence syndrome. Okay. Every 25 minutes, a baby is born suffering from opioid withdrawal. It is prevalent. We need to be aware of this, and we need to focus on it anytime we have a pregnant woman who may be using. So what is important with MAT? Well, it requires medical supervision. It's not a substitute. It's not something that works by itself. It's not a replacement. We need to use it in conjunction with ongoing therapy, and know that a mom will not necessarily need to remain on MAT forever. The brain has the ability to get healthy again, but women will need to stay on medically assisted treatment as long as necessary for them, and it's very individual based on each individual patient. With MAT, we can help maintain a stable blood level, which is so critical for the fetus. If the blood level goes up or down the slightest bit with opiates, it really can impact the baby's well-being, and particularly it can really impact the health of their heart. MAT also helps to suppress cortisol levels, which we know is very important in being able to maintain the proper growing environment for that fetus and for mom to be healthy as well. MAT does also decrease the risk of HIV and hepatitis B and C. In addition, it can decrease the need for hospitalization, as well as the severity of illness. And importantly, it can help decrease mom's risky behaviors and helping her to be more engaged in prenatal care. and following help her to be a functional parent for her baby. And we've talked about this on prior slides. If a mom is stable on an MAT and she is not experiencing any cravings or any symptoms of withdrawal, there will be a decrease in criminal behavior. She will not need to engage in things to help her procure what she needs to be able to maintain her high and decrease her discomfort. Folks often think that methadone can damage parts of the body, and this is not true. Methadone often helps people to be able to stabilize, so they may become more aware of other things going on with their body. It's not that the methadone can cause any damage in bones, liver, kidneys, brain, heart, lungs, reproductive systems, our immune systems, and other vital organs. Methadone, which is the gold standard of choice for pregnant women who are using opioids, will not decrease any function in any of these areas. The most common medications used for pregnant women include Suboxone, which is a combination of buprenorphine and naloxone.
Oh, that's not for pregnancy. Oh, no.
No, no, no. Thank you, Judy, for that. Oh my gosh, thanks for correcting me on that. We want to avoid Suboxone because naloxone is very dangerous for the fetus. Buprenorphine is being used a lot right now, along with the methadone we talked about. And Vivitrol, which it's long-acting. People receive a shot, and it lasts in the system for 6 months. And research is now showing that it also helps with substance use disorders with cocaine as well as alcohol. Right now, Vivitrol is being used a lot in the criminal justice system. Vivitrol is definitely being offered, and especially before release. We know that recently there has been mass release of inmates from county and state jails. And most of the folks who are dealing with a substance use disorder for opiates will accept Vivitrol as a form of treatment. And that period will help people to be able to link up with other services they need to be able to stay healthy and care for their children. Okay. So, I'm sorry, the top of my slide is being cut off. I'm going to move this over a little bit. Okay. So other medically assisted treatments include the following. If folks are dealing with opiates, they might be given naloxone for cravings. They may be given baclofen, which helps to relax muscles and decrease spasticity. Vivitrol, which we just discussed, it's a release injectable suspension. For alcohol, Antabuse is helpful in decreasing headaches, nausea, vomiting, chest pain, sweating, blurred vision, and breathing difficulties. Camprol is also used, and that helps to protect the brain from overexcitement when people are going through withdrawal. The gabapentin can also help reduce alcohol cravings and the anxiety and depression that often accompanies this. With cocaine, they're finding that modafinil is helpful, again, in reducing cravings. And for smoking cessation, and we're talking about tobacco, not marijuana, bupropion is found to be very helpful in reducing cravings. Often that will be packaged as Zyban, which is just the packaging name that's being used for the bupropion. Many may know that more as Wellbutrin versus bupropion. And my slides just froze again. Okay. So I'd like to just talk about units of drink. And often we're just not aware of how much we're drinking, even in a social basis, okay? So what is considered a unit of drink? It's either 12 ounces of regular beer. So when asking people what they're drinking or how much, and they say, I'm only having 2 beers a day, well, we need to make sure we're talking about 12 ounces of beer, not 42 ounces of beer, which also is available. It can be 8 to 9 fluid ounces of malt liquor, 5 ounces of table wine, 3 to 4 ounces of fortified wine, such as sherry or port, 2 to 3 ounces of cordials, liqueurs, and aperitifs, 1.5 ounces of brandy or cognac, which is basically a single shot. And for distilled spirits such as vodka, bourbon, whiskey, etc., it's 1.5 ounces as well, which is a shot's worth. So very often, just to think about, you're going out for dinner, you're ordering a glass of wine, and you think you're only having 1 glass of wine. Very often, they're giving you way more than 1 unit of drink. So just be aware of these amounts to help reduce risky drinking. Binge drinking is particularly risky, especially for pregnant women. And binge drinking can be categorized as a person who's not drinking really at all during the week, but they are drinking a lot on the weekends. It also pertains, again, to the amount of alcohol being consumed within a reasonable period of time, about 2 hours. So again, whether we're talking 12 ounces of beer, 1.5 ounces of distilled spirits, or 5 ounces of wine. For women, anything over 3 units of drink within a 2-hour period is considered risky drinking or binge drinking. That can cause more harm to the developing fetus. Men are able to metabolize alcohol easier than women are because they have more enzymes in their liver to be able to break down the alcohol, the ethanol, before it's distributed into their bloodstream. So for men, anything over 4 units of drink within a 2-hour period is considered risky drinking. And I just want to speak about a DUI, and that is driving under the influence. It's not necessarily driving under the influence of alcohol. It's driving under the influence of any substance. And within the state of New Jersey, we have what's called intoxicated driving resource centers, so that people who are convicted of a DUI, they are referred to an intoxicated driving resource center for further screening and assessment and education to be able to help them avoid that happening again. And just to mention the blood alcohol level that constitutes driving under the influence is 0.08. So anything higher than that does constitute driving under the influence. And for people under the age of 21, there is no blood alcohol concentration that's acceptable. So that's important for us to educate our under 21 years of age folks when they are driving a car. Okay, so we know alcohol really affects a growing brain. It is actually the most toxic substance that can really impact developing brain cells. And it attacks everything, whether we're talking the cortex, the cerebellum, which is responsible for our fine motor skills, our coordination and our balance, and our brain stem, which, as we know, controls our breathing, heart rate, and being able to maintain healthy body temperatures. The limbic system is also impacted, which includes our memory, our ability to learn, and even our levels of reproductive hormones. Alcohol poisoning is very common, especially because of the pattern of use, and particularly amongst young people. Young folks are really looking to get as wasted as they can in the least amount of time with spending the least amount of money. Unfortunately, many people with alcohol poisoning, if they lay down, and their friends and family help them to lay down so that they can sleep it off, they're at very high risk of choking on their own vomit because of that shutdown in the brainstem. It can also cause irregular heartbeat, cardiac arrest, difficulty with breathing, and breathing can cease. Also, there can be a dangerously low body temperature, low blood sugar, which can lead to seizures, severe dehydration, definite brain damage, and ultimately death. So a message that's very important is for folks not to let someone who appears to have drunk too much to go ahead and lay down and sleep it off. It is important to call 911. And I think I missed a point I wanted to make. Yes. The Good Samaritan law is really important for all of us to know. Many people are reluctant to call 911 for their friend or their family member, but it's so important to do so. If you call 911, you give the address and the necessary information and stay with that person until help arrives, there will be no legal ramifications. This is covered under the Good Samaritan law. And that's really important for us to educate, particularly our youth about. They need to call 911 and it can really help save their friend's life. Okay. So how are youth abusing alcohol and putting themselves at such high risk for substance use? For alcohol poisoning. They're using energy drinks with alcohol, which is a setup to drink more because it tricks the brain into thinking you're fine and you can continue to drink. Very creatively, our youth have also discovered that if they take tampons and soak it in vodka or any other distilled spirit, and then either insert it anally or vaginally, the vodka is immediately absorbed right into the bloodstream without having to go through the whole digestive system. So you can get high pretty quickly. Alcohol is also being smoked, very often by vaping. You can use alcohol pops, which are sold in many places. The drinking games, of course, enhance alcohol consumption. And also playing games with movie or television, where, you know, the minute someone says this, take a drink. If someone makes this gesture, take a drink. Again, it just promotes heavy drinking. And we know the party games that go on to also increase consumption. A lot of youth are also taking gummy bears and soaking them in alcohol. So that way they can continue using no matter where they are. Kids are taking these gummy bears to school and ingesting them throughout the day, maybe as they're going out to dinner with their parents or their friends. They can be having this little baggie of gummy bears with them that have been soaked in alcohol. The use of beer bongs is also particularly dangerous. And basically a beer bong is a huge funnel attached to a tube. Someone holds it up for you and pours alcohol through that tube. And so you're ingesting a large amount very quickly. All of these present high risk, particularly for our youth. Okay, so now we're going to talk about alcohol use during pregnancy. And it's important to note that damage to a fetus in utero can happen really, really early on. Damage can actually begin before women even know they're pregnant. There's really only a 2-week grace period following conception that potentially is not dangerous to drink. But once that fertilized egg implants in mom's uterine wall, damage can begin right away. So our moms are more prone to seizures, liver damage, heart damage, stomach damage, and withdrawal can be particularly risky and can cause hypertension, tachycardia, and premature labor. The physiological damage to unborn children is tremendous. And again, this is so important. Of all substances of use during pregnancy, alcohol presents as the most dangerous on a neurodevelopmental level. So if your mom is presenting with problems with her opioid use, she's smoking cigarettes, she's using hallucinogens, we may not be looking for that alcohol consumption. But again, if women are using any substances, more than likely alcohol is in the picture. Now, women may say, I don't have a problem with my alcohol use. That does not mean they are not consuming alcohol. So that's very important. And as that child who has been exposed in utero continues to develop, they can truly develop many behavioral problems. With other substances, once the newborn gets through her medically or his medically fragile period, they really can go on and be okay. They may be prone to developing mental health issues and or substance use issues as they get older, but they can also live fully functional, happy lives. Not the case with alcohol. We're talking brain damage, and brain damage doesn't ever go away. So that brings us to fetal alcohol spectrum disorders, which we know is basically an umbrella term that's used to describe the range of effects that can occur in a person's mother who drank any amount of alcohol at any time during pregnancy. And it can include physical, mental, behavioral, or other learning disabilities with possible lifelong implications, as I mentioned. And the sole cause is consumption of alcohol during pregnancy. And again, I can't emphasize this enough. It is the most dangerous substance that a pregnant woman can use. So we really encourage, if women are trying to get pregnant, they should stop all alcohol consumption prior to stopping use of effective birth control. Because many women will stop drinking once they know they're pregnant, but damage may have already happened. Okay, so if we're dealing with a person who did experience alcohol exposure in utero, their brains may be short-circuiting. So it's really important when working with patients to really check level of understanding. And we really need to not just ask, do you understand? Do you have any questions? We need to really ask them to reflect, what does that mean? How would you describe that? What did you just hear? I want to make sure I communicated clearly. Could you tell me what you just heard? In that way, as kids become adults and they do have brains that are impacted by that alcohol exposure in utero, we can help them function better. and to be able to follow through with what we're asking them to do as healthcare providers. Write it down for people. That's always really, really helpful. Or suggest they write it down as you're speaking. Break things down into simple steps. Often people are nervous and uncomfortable anyway, being in a healthcare setting, and everything can be overwhelming. So breaking things down into small steps is very helpful. And see if we can help with the actual task rather than instructing a patient to make a certain phone call or set up a certain appointment. How about we even just take that little bit of time if we can and help them make that phone call? Okay. And preparing individuals for changes in schedule is very important. Very often, a brain that's compromised by alcohol exposure has a lot of trouble regulating their time and often work best with specific routine. So anytime there is a change, we really need to help give people a lot of warning and help them prepare for that. Those are just a few ideas in helping folks who might be compromised by alcohol exposure. So now we're going to move on to marijuana. There is much higher risk for blood poisoning once edibles became popular. And edibles are often designed to appeal to youth because we can find them in sweets and treats and baked goods. And again, our gummy bears, they're very commonly used. And marijuana is often manipulated now to make it stronger. And it is developed into extracts and concentrates, which may be called such things as hash, honey oil, wax, keef, the list goes on. We can never keep up with all the names as they develop, but just know there are so many. So if you hear a patient using a certain word you've never heard of before, ask what it is. They'll certainly give you an education. Extracts can contain 40 to 90% THC. When smoking marijuana that has not been manipulated, typically the concentration of THC is about 20%. So please note that discrepancy. So moms using marijuana during pregnancy also presents high risk. And unfortunately, there are so many mixed messages now with pregnant women using marijuana medicinally to help with uncomfortable symptoms of pregnancy, such as nausea, difficulty sleeping, lack of appetite, aches and pains, etc. But it's important for us to be able to provide the education that moms are at higher risk for miscarriage, preterm birth, becoming forgetful, having a slower reaction time, which could be dangerous, toxicity to their respiratory and immune systems, that increased heart rate again, hypotension, and prolonged or arrested deliveries. And in addition, there can be abnormal bleeding. For the babies, there's a higher risk of infection, a shorter gestation, that low birth weight again, and small head and brain. These children may have a lifelong short attention span. They may show a increase in a startle response at birth and have tremors and disturbed sleep patterns. Also, boys are known to have an increase in behavioral and cognitive disabilities if exposed to marijuana in utero. I also would like to mention Delta 8, which is a fairly new product out on the market. This is synthetic marijuana, which takes the CBD in a hemp plant and converts it to THC. Household chemicals are used to make that conversion. And these products are not only sold in dispensaries, but also sold in marketplaces and online, and it's legal to do so. Many customers think they're just purchasing CBD products or hemp products, and they may be laced with this Delta 8, and therefore they're becoming intoxicated unknowingly. Often it can be sprayed on hemp. And again, it's in the things that we're finding marijuana in, like tinctures, gummies, chocolate, and infused beverages. What we might see as healthcare providers is a person with lethargy, clumsiness, decreased psychomotor activity, increased heart rate, which then quickly progresses to a decreased heart rate, decreased blood pressure, sedation, and maybe even coma. So we really want to find out what our patients have used, even if they're saying they've never used marijuana. And they might be speaking truthfully. They may think they're using a CBD product or a hemp product. Presently, there are no antidotes for this. It's merely about treating the symptoms. And what's really important is to monitor these patients very closely and to report to poison control. Poison control is actually set up a specific code as they're beginning to collect data of the people who are impacted by inadvertent use of this product known as Delta 8. Very scary stuff. And we're going to continue to see more as folks figure out different ways to manipulate substances for people to become intoxicated and addicted more quickly. Okay, so now we're moving on to tobacco. We know this is one of the highest risk factors for poor outcomes for mom as well as for her child. Again, that high risk of miscarriage, preterm delivery, higher risk of ectopic pregnancy, as well as anemia, that risk of placental abruption, and premature rupture of her membranes. Babies can be born not being alive. Again, that low birth weight, very small for their gestational age, and at much higher risk for SIDS as well. So we do really encourage the use of nicotine replacement therapies for people who are trying to quit smoking. And this does include pregnant women. It is felt that there is less risk using these products, which are FDA approved, versus actually smoking cigarettes. And these medications include nicotine patches, which comes in 3 strengths, 7, 14, and 21 milligrams. In addition, there's nicotine gum, which also comes in different strengths, along with nicotine lozenges. All of these can be bought over the counter. And many times, these products can be reimbursable if prescribed by a doctor for smoking cessation. Nicotine spray is another NRT, which a prescription is needed for. This works really, really quickly. A lot of people like this. However, those who have substance use issues may not like the spray very much because the drip actually is reminiscent of using cocaine, and it might act as a trigger for people. There's also an inhaler, which is similar to an asthma pump. That also acts very quickly, and that too requires a prescription. Other medications that are used for smoking cessation include Zyban, which I mentioned earlier, is bupropion or Wellbutrin. And Chantix is another medication that's used for smoking cessation. The jury's out on that. Some people really love Chantix. They find it works really well. Other people find it really difficult to use because it does cause a lot of nausea and can sometimes cause a metallic taste in your mouth, which can be very unpleasant. Okay. Many people are turning to vaping as a way of reducing the risks from being addicted to nicotine. Not a great idea. It's called many things, as you can see here. But be aware of the term ENDS, which refers to an electronic nicotine delivery system. These same products rather than using nicotine, are also being used with concentrates of THC. So the youth we see drawing on their vape pen, their hookah pen, whatever you want to call it, we really don't know what they're using. So it's really worth paying attention and taking a look at that. The concentrations of nicotine do vary, but often they're higher than cigarettes when we're talking about vaping. In one cartridge equals about 1 pack of cigarettes. And if you are able to take hits off of your vape pen all day long, you could be consuming a few cartridges and therefore way more than a pack of cigarettes a day. The flavoring that's used to make all of these things real palatable are linked to popcorn lung, which is a scarring and obstruction of the smallest airways. This also can happen in cigarettes, but it does occur much more quickly if people are taking hits off a vape pen on a regular basis throughout the day. Pediatric studies have found increased levels of 5 carcinogenic compounds present in vape pens. So the myth that vaping is safe is just not true. These devices also can explode, causing burns, and typically these are the bigger devices that are really amped up to be able to release more vape at a time. And it really can cause injuries, and there are many documented cases of that, and it certainly can be fatal. Our biggest problem with vaping is that we do not have long-term studies yet. So we are just beginning to really recognize vaping as an unsafe way to take in nicotine or THC products. Okay. These are just some more concerns. There can be a lot of difficulty with coughing and mouth bleeding and throat bleeding and gum disease, and it can impact immunity and likelihood of infection, which does not speak well during this time of COVID. It can also interfere with wound healing by destroying the mitochondria that provide energy in cells as they divide to close up injuries. Many surgeons do ask their patients to stop smoking cigarettes and vaping products prior to surgery so that healing will not be impeded. Okay. And there's also a possibility of nicotine poisoning when we're talking about these flavorful cartridges that can often be very appealing to little ones, as well as pets. There has been a large increase in the calls into poison control as a result of vaping products. So here are just some current trends that are being used. Just trying to look, I know we're almost running out of time, but there are just so many ways to be able to get high, whether we're talking cough medicine, which can be bought over the counter. Most stores now keep these products behind the counter to help control that. But even household products, kids are real good at inhaling common household products. So just be aware of what's happening. And on the bottom, you can see beer bonging. That's what that looks like. And bath salts are synthetic. And if it says on the container, not for human consumption, it means it's a synthetic substance to get high. And again, these things are sold anywhere and everywhere. So our kids are really vulnerable. So now I just want to look at what might influence how long substances remain in the system. It depends on the type, how much you're using, how frequently, what's your method of use, have you built up tolerance to that product, are you using other substances at the same time, how long is the half-life of that product, and what's the metabolic rate, how about hydration levels, body mass, weight, physical activity, other medical conditions, and even ethnicity and gender all play a role in how long substances can remain in the system. For example, marijuana often will remain in a woman's system longer than in a man's because we have a higher fat content and than men do, and that's important to know. Okay, this slide is showing different different drug testing methods and for how long they might be able to detect something in the system. And as you can see on this chart, and these slides are available to everybody, that it really does vary. In urine, it's pretty much looking more short term at substances. Hair gives us the longest time frame, and especially the longer your hair is. So that can really track up to 90 days, which would be the last trimester in pregnancy. Blood also varies, but it's not going to give a very long history of what may have been in the system. Saliva also is pretty short-lived, so that's not always accurate either. This slide goes into different testing, and I'm just going to go over this really quickly. Within urine, it may be good to do a urine screen at that preliminary prenatal visit because it sets up the ability to do an intervention. It also can be used to diagnose NAS because you'll get a quick response from the screen. Meconium, which begins to form in the second trimester, is sometimes problematic because that first bowel movement might be missed. It might also be complicated by other drugs that are used during labor and delivery. And with high drug exposure, that first bowel movement can be delayed. Maternal hair can, as I said, detect months depending on hair length, but it's very invasive. And not the first test that we're running to use. Neonatal hair can also be tested, but it doesn't work for detecting marijuana, and it doesn't detect long-term use. And it is a good source to diagnose NAS if the meconium is not available. Testing the placenta can be helpful for picking up on medically assisted treatments, but it will not provide dosage or amount. The umbilical cord is complicated because we don't know if it's an accumulation of mom's use or what's been built up in that umbilical blood. It is particularly sensitive to marijuana though, but there are discrepancies in the results you get from the blood versus meconium. And because it's considered a waste product, it can be used universally and can help detect methamphetamines, cocaine, opioids, and cannabinoids. Okay, so when do we need to report? This is really important. Please read this and go through it. I know we're very short on time, but these are the reporting guidelines. Truly, if there's any proof that mom's been using or that the baby born has been impacted by exposure, the call has to be made. And the line is available 24 hours a day, 7 days a week. And regardless of the circumstances, all substance affected newborns must be reported. On our next slide, it just froze again. Let's see if I move that a little. Uh-oh, why did that happen? This is not a good time for this to happen. I'm going to exit and come back in very quickly and see if that helps. Oh my, that brought us right back to the beginning, but that's okay. Let's go back. Let's see. Okay, so I hope we're all aware of the term plans of safe care. The DCF has created a brochure called Plans of Safe Care, and it is available on the site listed above. Here are just some generalities for you to understand, but please access this brochure. It gives so much information. But what we need to know is policy and procedure for whatever agency we're working in, okay? Because each birthing center or hospital has their own policies and procedures for reporting. And screening is not uniform across the state. And even within a municipality, different local DCP&P offices might have their own procedures in how they decide to open a case or just open a file. But we do have to call, if there's evidence of substance use exposure after birth, or maternal positive screens, symptoms of NAS, displays of FASD, if there is medically assisted treatment being used during pregnancy, even if opioids are prescribed for pain management or other medical or other substances for medical conditions, and the use of legal and illegal controlled substances, and if a mom is not engaged in treatment or recovery. Okay. Controlled substances include heroin, fentanyl and other opioids, cocaine, methamphetamines and other stimulants, PCP, marijuana, hallucinogens, as I just mentioned, prescription opioids, along with sedatives, tranquilizers, depressants, methadone and buprenorphine, and alcohol. All of these are reportable as controlled substances. And I know I'm going very quickly, but here are a whole bunch of support groups that are available, which are great to have at hand because they're helpful to give to patients who may need some help and support. I also just want to mention that for fetal alcohol spectrum disorders, we are very lucky in the state of New Jersey in that we have regional diagnostic centers that were established back in 2002. And these centers help to identify, screen, diagnose, case management, provide case management referrals, as well as education outreach. They use a multidisciplinary approach, as each child exposed to alcohol in utero will present very individually. So it's a full panel of professionals to help determine what specific areas were impacted by alcohol consumption. And it depends when alcohol was used and what brain cells are developing at that time. Again, this is more this is another list of things that can be provided for individuals with fetal alcohol syndrome or fetal alcohol spectrum disorder. And early intervention is the most helpful thing that we can really offer. So if you detect that children are not meeting their developmental milestones and being seen by healthcare providers and providing interventions and things are not helping, it's really important to know that we can reach out to any of these developmental centers for further assistance in the state of New Jersey. Here I have listed the centers, and following is our lengthy list of in our bibliography, as well as helpful websites. I have included the website specifically for the Delta 8 that I mentioned, including the plans of safe care, and also to be able to reach out to 844 REACH NJ, which can help with any referrals for any level of addiction treatment and support. So that does conclude my presentation. We are here as the staff from the Perinatal Addiction Prevention Project to help all healthcare providers find the resources they need help with referrals, and also to provide prevention and educational services. And we are available within Central New Jersey through the Central Jersey Family Health Consortium, as well as the consortia in the northern part of the state and the one in the southern part of the state. And we are all easy to contact and available to help make your jobs easier as you work in the trenches with your patients. So thank you. Here is my contact information. Please feel free to reach out. And now we can open it for questions. So I'm going to stop sharing my screen.
Debbie, that was really extremely insightful. And again, sorry everybody for some of the glitches we had today on our Zoom and our computers. And please start typing questions in the chat box. Some of the questions below are related to receiving the slides, for example. Basically, the presentation will be posted online that you can access again, and you can obviously invite others to access. As far as the CE credits, only those who watched it live today will be receiving CE credits if you watched it in the entirety. And again, you will be receiving an email next week with those links. One of the questions that I have is that you had talked about reporting, and I know throughout the state, this is a very difficult decision sometimes to make. But I'm just curious, when is that call usually made? Is it made like upon admission or before discharge from the hospital, or during, the antepartum period? I was wondering if you had any information like that, Deb.
Certainly. It can be reported during prenatal care if it's noted that mom is having difficulty. Definitely can be reported during labor and following delivery. Now, reporting does not mean that a case is opened. What that means is a person from DCP&P will come and speak with mom and give her a lot of positive reinforcement and validation for things she's doing well, like she followed through the prenatal care, but noted that she's on prescription amphetamines or a depressant or an opioid for pain management, means that a file will be opened. So DCP&P will avail themselves to provide whatever supportive services that mom may need. The goal is definitely to keep mom and baby together. It's not to tear apart a family unit, but to offer as much protection for the child as possible, and to also support mom and help her engage in treatment if she needs it. So the person who is coming from DCP&P will make that determination whether a file's open and help is offered, or a case needs to be open where much more scrutiny will be available and many more supports. So it really can happen at any time through the process, but we really encourage conversation to happen prior to labor and delivery. If patients report prescription medication they are using prior to entering labor and delivery, there is much less likelihood a case will be open. It will just be that provision of help and support. So the more upfront we can be with what's being used, the better it will be for both maternal and fetal outcomes.
Somebody typed in, as a home visiting nurse, if they identify an issue that they deem reportable, do they go directly to DCP&P, or do they? Oh, okay. This is for the new program that we're starting, the Family Connects. So the question was, should the nurse call directly to DCP&P for their concerns versus going through the Central Jersey Family Health Consortium or the Trenton Health Team? And I think at that point in time, we're going to be creating algorithms for that with regards to who to contact when. So I'd probably say I'll get back to you on that question because that's still all in the planning. But one also thing that got brought up, Debbie, was that somebody mentioned that you can direct mothers to the local crisis centers
Yes.
as another alternative.
That is true, and those will be listed on the DCF website as well as DOH.
And another question would be, when you talked about vaping, it's such a hot new topic, and surprised that the amount of tobacco in those cartridges.
Yeah, it is concentrated. And the point of a vape pen is you can pretty much use it anywhere, anytime. So our kids are using it on the school buses. They could be sitting in the back of their classroom. They rig up ways to take hits off of it. So you can really gain very high levels of nicotine in the blood. And they're very flavorful. So it's a setup to just keep taking hits off of it.
Any other questions from any other participants? Please feel to type now. Okay. Well, again, I'm going to wrap this up. Once again, Debbie, you did a fabulous job. Your knowledge base as an expert in this area really comes through very, very apparently. So again, thank you again for your time. And I wish everybody a very happy and healthy weekend. Take care, everyone.
Thank you for joining us.